Welcome back to The Explainer. Today, we're putting on our public health detective hats. We are going to track down the absolute truth behind the numbers, specifically uncovering the epidemiology of breast cancer. It's going to be a fascinating journey, so let's get into it.
Whenever you open a news app or read a health headline, you're constantly bombarded with these massive, staggering statistics. Things like thousands diagnosed or rates are on the rise. But have you ever actually stopped to ask yourself, where do those numbers come from? Who's doing all this counting? And honestly, how do we know the data isn't just flat out lying to us?
Okay, let's dive into this. Here is our roadmap for the explainer. First, tracking disease data. Second, incidence, prevalence, and mortality. Third, breast cancer in the UK. And finally, the age standardization factor.
Section 1. Tracking disease data, the detective work. Let's start right at the source.
So to understand a disease, we really have to understand where the population data comes from. And this continuous flow of information isn't just about people occasionally answering surveys. We rely on heavy-hitting national institutions. We're talking about the Office for National Statistics in England and Wales, NISRA in Northern Ireland, and, of course, the once-a-decade census that gives us our essential baseline population numbers. But when we're looking at cancer specifically, the real heroes are the cancer registries. They actively pull from multiple sources, like electronic healthcare records and pathology reports, just to make absolutely sure every single case is carefully tracked and standardized.
Let's see how this actually works in the real world with something like a death certificate. Imagine an 83-year-old woman. She has a history of coronary heart disease, falls at home, fractures her hip, goes in for surgery, but tragically passes away days later from a blood clot in her lung. How does all that get recorded? Well, a medical examiner has to be incredibly precise. Line 1A, the direct cause, is the pulmonary embolism. But what caused that? Line 1B is the deep vein thrombosis. And what caused that? Line 1C is the fractured neck of the femur from the fall. Her heart disease is listed down in Part 2 as a contributing factor. So tracing this incredible chain of evidence all the way back, the true underlying cause of death that gets coded into the national statistics is actually the fractured hip.
Moving on to Section 2, the vocabulary of disease, incidence, prevalence, and mortality.
Now that we know how the data is gathered, we need the right vocabulary to actually make sense of it. First up is incidence. Think of incidence strictly as the event of moving from health to disease. It's simply the number of brand new cases popping up in a population over a specific time period. So, if you want to know how fast a disease is spreading right now, you look at the incidence rate.
Prevalence, on the other hand, is the totem pool of the disease. It's the proportion of the population that has the condition right now. And that combines both the brand new cases we just talked about, plus all the pre-existing ones. Now, a high prevalence could absolutely mean a high incidence. But, and this is key, it could also just mean we have really great treatments so people are surviving a very long time with the disease without necessarily being cured.
We can actually break prevalence down even further, and it's super useful. Think of point prevalence like snapping a photograph. It's a literal snapshot of who has the disease on one exact date, say January 1st. This is brilliant for tracking long-term chronic illnesses. Period prevalence, however, is more like recording a movie. It captures anyone who had the disease over a span of time, maybe a whole year, which makes it perfect for short-term or episodic illnesses like the flu.
And finally, we have the grim but absolutely necessary metric, the mortality rate. This is pretty straightforward. It's the number of deaths due to a specific disease per year divided by the total number of people in that population. Section 3. The reality. Breast cancer in the UK. Let's put these terms to use. So the crucial point here is how these concepts map onto real populations. Every single year, around 56,000 new cases of breast cancer are diagnosed in the UK. That right there is our incidence. And because of this high incidence, a woman born after 1960 and living in the UK has an estimated 1 in 7 lifetime risk of developing breast cancer.
Just to illustrate the sheer scale of this challenge, data from Northern Ireland reveals that breast cancer accounts for a massive 29.1% of all female cancers. It takes up a huge slice of the overall picture. Across the UK, it is the most common cancer, representing 15% of all new cancer cases across both sexes.
But when we look at mortality, the story gains a lot of nuance. While about 18% of breast cancer cases occur in women under 50, the mortality rate drastically spikes as we move into the older age brackets, particularly for women in their 70s and 80s.
However, I do have some incredibly positive news here. The overall trend gives us tremendous hope. The 5-year survival rate for women in England and Wales has climbed steadily since the 1970s. Back then, it hovered around 50%. But today, thanks to better screening, early detection, and amazing advanced treatments, over 85% of women are surviving beyond 5 years, and nearly 76% are predicted to survive beyond 10 years.
Section 4. The plot twist. The age standardization factor. Let's look at one final vital concept.
Now, what's really interesting is this question. What happens if one population is simply older than another? Consider the stark demographic contrast between two totally different nations. Back in 1991, South Africa had a classic triangle-shaped population, meaning a massive base of young people. Contrast that with Sweden around the same time, which looked more like a column, featuring a huge proportion of older citizens.
Here's the catch. Because cancer incidence and mortality are heavily tied to age. If you just compare the raw, basic numbers, what epidemiologists call crude rates, Sweden is going to look like it has a terrifying cancer epidemic compared to South Africa. But there's no epidemic, it's an illusion. Sweden's rates look worse simply because they have way more elderly citizens who are naturally at a higher risk. If you don't account for this, the crude data will absolutely lie to you. We need a mathematical fix.
That mathematical fix is what we call age standardization, and there are two main ways to pull it off. Direct standardization takes the specific disease rates from your different countries and applies them to a hypothetical standard population, so everyone is playing on a level field. Indirect standardization kind of does the reverse. It applies standard rates to your country's unique population structure to figure out if you have more or fewer deaths than expected. Both of these statistical tricks strip away the age bias, and only then can we accurately compare the true impact of factors like diet or pollution between two completely different nations.
So, look at what we've covered today. We've gone from tracking a single fall on a death certificate to mathematically leveling the playing field across global populations. You are now armed with a powerful epidemiological toolkit. The next time you see a dramatic health headline that's clearly designed to shock you, I want you to pause. Ask yourself, what is the actual incidence here? What's the prevalence? And most importantly, are they feeding me crude rates or have they actually adjusted for age? Stay curious, stay critical, and I will see you on the next explainer.